Hi, thank you all so much for having me. Thank you, Dr. Malik, for inviting me today to join y'all on this nephro-oncology grand rounds. I'm really excited to be here because I think that I share probably a lot of patients with a lot of you. As Dr. Malik has said, there's so much intersection between plasma cell disorders and renal insufficiency that we get a lot of patients that I send your way and vice versa. So I'll kind of take a step back from specifically MPG and MID. It's alphabet soup, and kind of talk about from a hematologist perspective how we think about monoclonal gammopathies when we see renal insufficiency, because oftentimes we don't have the diagnosis at hand, and so a lot of our work is kind of figuring out if they're related or if they're just coincidental, they're unrelated, and then next steps, how to treat, etc. So I'll be talking about that mostly today. Here are my disclosures. So I'll frame my talk with some common referrals that I think put most of our common referrals that put most of what we see into 4 different buckets. Then I'll talk about some diagnostic considerations, followed by some treatment strategies. All right, so from a hematologist perspective, these are 4 cases of mine, with the last one actually being my colleague, Dr. Cowan's, that I think do a good job of representing a lot of what we see in the plasma cell disorders group. So the first patient is a 59-year-old man who was found for workup for neurosyphilis, actually, to have an IgG kappa that was 3.8, a kappa free light chain of 66 milligrams per deciliter, ratio of 35, and a creatinine of 2 that was previously normal. So when we get referred to someone like this, the question is usually, is the AKI due to the paraprotein? The second case is essentially the same question, is the AKI due to the paraprotein? But the major difference here is that the monoclonal protein is very small concentration. Here, the IgG lambda is just too small to quantify. And we also see some proteinuria here that has been progressive over a pretty quick time, just 3 months. Here, the light chains are normal. So it's the same question, but different concentrations. Then number 3 is a 69-year-old man that has extremely high free light chains. So lambda of over 2,000, a ratio of essentially 0, creatinine of 3, a macrocytic hemoglobin, and then about 17 grams of lambda Bence-Jones. And the question that we have here is, we essentially know the diagnosis, and it's how do we treat light chain cast nephropathy? This is one of our emergencies. And then the last question, the last case, Dr. Malik had used us as an index case. And so I will touch upon PGN MID. When we already have the diagnosis of MGRS, how do we treat that? So as you can see, lots of overlap with the intersection between monoclonal gammopathies, renal insufficiency, these abnormal kidney function labs. And so, this is a very common thing that we try to think of if they're related or not. So just taking specifically, as Dr. Malik had mentioned, they are our most mature of the white blood cells within the B cell lineage. And so what that means is that there's a ton of genetic processes that go on in order to create the antibody diversity that we need in order to be able to recognize the different antigens that we have, that we're exposed throughout our lives. So within all these different kind of genetic changes that happen through this normal maturation process, it makes sense that these things can go awry and plasma cell disorders can develop. But that said, there also can be monoclonal gammopathies associated with B cells, which is a slightly earlier cell within this maturation process. Usually here we're looking at IgM. So when we think about plasma cells, we all know that normal plasma cells are responsible for antibody production. Again, they go through an incredible amount of genetic changes through their maturation process, with each plasma cell kind of having like a fingerprint of a different type of antibody that it produces, with a different amino acid sequence in the antibody binding domain of the B cell receptor. So this creates our polyclonal antibodies, and everyone has them, and they're all composed of both a heavy chain and a light chain, as we all know, just backing up to our typical immunology to kind of understand what we're looking at when we think about monoclonal gammopathies. So in terms of these antibodies, a heavy chain is what we're referring to when we think about IgG, IgA, IgM for those B cells, IgD rarely. And then the light chains we're thinking about for kappa and lambda. This is attached through a disulfide bridge. And so polyclonal antibodies are everyone has them. And so we expect to have a normal number of different quantitative immunoglobulins within our system, a normal number of kappa and lambda that we typically see. However, what happens in plasma cell disorders, as we all know, is that instead of having all these different types of antibodies from all this antibody diversity, we have one plasma cell that essentially is one fingerprint for one antibody that is being produced. And that plasma cell replicates over and over again. And so instead of creating this entire antibody diversity of polyclonal proteins, it creates a monoclonal protein over and over again. And so this is what can be causing the problems of monoclonal gammopathies. We're all very familiar with our tests that can detect these monoclonal proteins, the SPEP and the free light chains. So essentially what an SPEP is it uses protein electrophoresis in order to separate proteins based on charge and size and shape, et cetera. So if we're all having just one of the same protein produced over and over and over again, that allows us to see an M spike as compared to the normal production of many different proteins within our normal circulation. So this is what's picked up on the SPEP in terms of concentration for an M spike. The immunofixation is then used in order to determine what type of monoclonal protein this is, like IgG, kappa, et cetera. The light chains are more of a proxy for the monoclonal protein. So this doesn't necessarily detect the monoclonal protein directly. And that's pretty important because these fluctuate very frequently, can be associated with a lot of different things that are unrelated to the monoclonal gammopathy specifically. And so really what we're looking at with the light chains is there's a normal production, again, of kappa and lambda for normal polyclonal antibodies that is expected. But what's happening in these monoclonal gammopathies is that this ratio is skewed towards either kappa or lambda, which allows us to suggest that perhaps there is an unusual production of one versus the other. So the sensitivity of just these simple blood tests and is about 98% to detect a plasma cell disorder. So plasma cell disorders, if they're there, 98% of them do have a measurable protein, but that means that about 2% is what we call non-secretory. In other words, we can't detect any kind of antibody within the blood, but this is also only as good as our best sensitivity is with the test that we have at hand. So it's always kind of improving what we can actually measure. If there is those 2% non-secretory plasma cell disorders, what happens is we need to have pathologic confirmation, so a pretty high degree of suspicion. We'll get a bone marrow to look at the bone marrow clone that will show the clonal plasma cells. You could get imaging that will show plasmacytomas, and then those have to be biopsied. Or in more serious cases, probably our most aggressive type of disorder is plasma cell leukemia, where we'll have circulating plasma cells within the blood. Plasma cells should never be seen within the blood. They are always within our bone marrow. So this is very wrong if you see them there. So at very minimum, all we really need to detect a monoclonal protein is really just the SPEP immunofixation and the free light chains. So really easy to detect a monoclonal gammopathy. And because it's so easy to detect the monoclonal gammopathy, it's pretty common to see them. So in one series, the prevalence of MGUS, or monoclonal gammopathy of undetermined significance, was 4%. In the largest scientific study ever conducted in Iceland, where pretty much everyone was invited to join, the prevalence was 4.9%, with those over the age of 80, the prevalence getting above about 13%. Different ethnicities have different prevalences. So some series show 13% in a country in Eswatini, other series show 11%. So all in all, really the point of this is that it's really common to have a monoclonal protein. And if we think about that as relative to something that we're all very familiar with, let's say diabetes, that we all see very commonly in our clinical practice, even though we're not treating that diabetes prevalence is about 11%. So taking that into comparison, if we're looking for a monoclonal protein, we probably will find it in a lot of cases. And so the question then always becomes, is the monoclonal protein related to any kind of clinical significance and organ damage, or is this really just completely unrelated and we just found it because we were looking for it? And so that's why I love, the plasma cell disorders. And because it's a lot of diagnostic challenges, oftentimes we don't just have someone that comes to our clinic with the diagnosis at hand. And so I want to talk about each of these referrals to kind of frame how we typically think about these diagnoses when we see an abnormal protein and kidney impairment, and if they might be related or not. So this first referral, again, is this 59-year-old man. He has hyperlipidemia and hypertension, and he has an IgG kappa that's 3.8, a kappa free light chain nearly 67 milligrams per deciliter, a ratio of 35, a creatinine of 2. By our definition, an M spike greater than 3 automatically puts us in at least a smoldering myeloma category, because that shows us a pretty substantial tumor burden that is underlying the monoclonal protein. So the question here, the fact that he has an M spike that's 3.8, is not whether or not he has smoldering myeloma or MGUS, but really whether or not he has smoldering myeloma or active myeloma. The difference here is really defined on the presence of end organ damage. The CRAB criteria, if you guys remember back to med school days. So high calcium, renal insufficiency, specifically light chain cast nephropathy, anemia, this is usually macrocytic, and bone lesions, specifically lytic lesions. The important thing here is that each of these criteria has to be due to the monoclonal protein. They can't just be due to random other things going on. In 2014, the International Myeloma Working Group expanded the criteria to not only include those that already had end organ damage, because why wait for that, but also near inevitable progression to end organ damage. So multiple myeloma now also includes bone marrow percentage greater than 60%, as well as free light chain ratio greater than 100. The reason there being light chains are nephrotoxic to the kidneys. And so the thought being that if you're heading that free light chain ratio greater than 100, there's near inevitable chance that you will get light chain cast nephropathy. So this person comes to us, M spike is greater than 3. Again, we already know that at least the person has smoldering myeloma, no hypercalcemia. The MCV is 82, so this is normocytic anemia and doesn't meet the criteria for a myeloma defining event. Being over 10 plus normocytic is probably not related. And so the only thing that we see here is a creatinine of 2. But the person also has hyperlipidemia, hypertension. Can we really say that this is a myeloma defining event? And this is something that we often see. And honestly, I've seen a lot of patients being told that they have myeloma, being sent to us for transplant evaluation, being on like years and years and years of therapy, intensive therapy, sometimes with a lot of detriment, thinking that the kidneys were the myeloma defining event, the only thing, and they really just don't have multiple myeloma. And it's pretty amazing how often that happens, and it's really terrible to see. So in these kind of situations, we just need to figure out the rest of the workup to make sure that there's not another myeloma defining event. So the bone marrow biopsy, if it was greater than 60%, that would be the other myeloma defining event. It's not, it's 30 to 40%, what we expected, at least above the 10% range. And then the PET scan, we do 2. You could either do a PET scan or an MRI for a sensitivity looking at plasmacytomas or lytic lesions, and it had none. So again, the question really is the creatinine related to the abnormal protein, those free light chains? And so again, just that emphasis that it's not always that the monoclonal protein causes the end organ damage. So as Dr. Malik had talked about at the beginning, when we think about myeloma, this is really a concentration dependent process. When it causes light chain cast nephropathy, we know that free light chains are toxic to the kidneys. And so since free light chains are cleared by the kidneys, the higher the free light chain levels are, the worse the renal impairment. So in our world, what we typically think about is that if the involved free light chain is less than 50, we pretty much don't think that this is due to light chain cast nephropathy. Of course, there could be those rare exceptions, but usually this is not something that we're really considering. In this situation, though, the case that I presented, the involved free light chain was 66. And so it's right in this middle that it could be, but maybe not, where in this study, at least 55% of people that had free light chains around this threshold did not have renal insufficiency. So what do we do when, we're still in this question? Well, that's really when we think about kidney biopsy. And so from a hematologist perspective, Sometimes we won't send them your way. And what we typically think about is that a kidney biopsy probably can be avoided if the involved free light chain is greater than 150. Then it's pretty likely that this is light chain cast nephropathy. If the majority of the proteinuria is Bence-Jones, if there's no other clear reasons for kidney injury, and if it's not the only myeloma associated defining event. If any of those are met, if any of those are not met, then we usually send them your way for renal evaluation, consideration of kidney biopsy. And this is probably one of the most common reasons that I get y'all involved. So moving on to a next kind of referral, which is similar but different. Here, there's no concern for light chain cast nephropathy. The light chains are essentially normal. I mean, they're both elevated, but the elevation of both of them is because of renal impairment with a normal ratio. And there's no concern for any other myeloma defining events. Calcium's normal, hemoglobin is essentially normal. I don't have the imaging here, but there was no lytic lesions. And so here we have a clone, a monoclonal protein that's too small to quantify, very small concentration. So the first question is, if we see this, the creatinine of 4, the clone too small to quantify, what is our next steps? Will a bone marrow necessarily be helpful? Is that what we need to do? And the answer is no. So a bone marrow biopsy would probably not help us in this case, and at least initially. So we don't necessarily perform bone marrow biopsies for everyone that we see that has a plasma cell disorder or an abnormal protein. That huge Icelandic study that I mentioned before, it's been incredible what it has kind of helped us discover about the like MGUSs and other types of monoclonal gammopathies. And they created this risk calculator to stratify or to give us the probability that a bone marrow will have more than 10% plasma cells. Why that's an important threshold, again, it differentiates MGUS versus smoldering myeloma. If it's likely that someone has smoldering myeloma, we'll do more workup to look for myeloma, to know about the quantification or to know about the frequency of monitoring. So we use this iStop-MM risk calculator pretty often. And so plugging in the numbers for this case, for example, the probability that this person would have had a bone marrow that was greater than 10% was only nearly 4%. So for this person, we don't necessarily need to do a bone marrow biopsy because probably this person does not have significant plasmacytosis in the bone marrow. And the only really reasons that we would do a bone marrow biopsy is to differentiate, again, MGUS versus smoldering myeloma. And then if we actually have end organ damage that is confirmed or suspected, then we need to do a bone marrow biopsy to confirm, quantify, and risk stratify the clone. Okay, so back to this case. So, there's no concern for light chain cast nephropathy here, no myeloma defining events. Really, the question comes here, we don't really need a bone marrow biopsy yet. So the question is really MGUS versus MGRS. Again, MGRS is really a low clone kind of disorder. We do not need, it's not concentration dependent. We do not need significant monoclonal protein around in order to cause harm to the kidneys. And so here we get kidney evaluations, renal evaluations for kidney biopsies as really the main way to differentiate an MGRS. And so we will send them your way pretty early on to tell us, is this something that you see any other reason for? But really that would be our way to confirm rather than any kind of hematologic evaluation before. The only time that a kidney biopsy can be avoided for suspicion of MGRS is for AL amyloidosis, where we could get pathologic confirmation on fat pad biopsy or bone marrow biopsy. So that's a time where we could do a bone marrow biopsy, or cryo or crystal globule anemia, where we could get skin biopsies. Otherwise, really, we're looking at the kidney biopsy. So this person that had a lambda monoclonal protein that was too small to quantify and proteinuria that was pretty rapidly progressive, didn't end up having AL amyloidosis. And just a few words about AL amyloidosis, because we've come such a far way with it, and that it's really rare, 9 to 14 cases per million person years. So why should we care? Well, the median overall survival, if there's not effective treatment, is only on the order of like less than a year and a half. But recently, we have such good treatment that this letter came out looking at a study that shows that people that have a cardiac complete response to AL amyloidosis have a normal life expectancy, which is pretty incredible in today's modern era compared to the 1980s, where the median survival was a year and a half. And so the key to this is really early diagnosis for AL amyloidosis to get that cardiac complete response. Unfortunately, about 20% of people get diagnosed after 2 years of symptom onset for AL amyloidosis. Seeing 1 in 3 people see more than 5 specialists. The nephrologist is key to the workup because the kidneys are often involved. So the plea here really is just have a very low threshold to suspect it, have a high suspicion for AL amyloidosis because it could be really meaningful in having really amazing outcomes with normal life expectancy. Unfortunately, from the renal point of view, it's really non-specific to have this to have a threshold. It's really just looking at proteinuria. The kidney function may or may not be affected, so just have it in mind. Okay, so moving on to treatment considerations. Going down to referral number 3. So this is someone that comes in with incredibly high light chains. Lambda is 2,163 milligram per deciliter. Ratio is essentially 0. Creatinine is 3. Hemoglobin is 7 with an MCV of 107, so macrocytic, and nearly 17 grams of specifically lambda Bence-Jones proteinuria. And so here, we already know that this person has multiple myeloma based on the labs alone. When those light chains are that high, and the ratio here for involved minus divided by uninvolved is greater than 6,000, the Bence-Jones is 16 grams, there's really no doubt in our mind. Macrocytic anemia helps support that. That said, we need to complete the evaluation anyway. Bone marrow biopsy did support this, greater than 90% plasma cells, and imaging to show us that this person also did have lytic lesions. But when we see such high light chains, this is one of our hematologic emergencies, and we need to treat as soon as possible. So when we see have a high suspicion for light chain cast nephropathy, as I said, this is usually one of our emergencies, and we admit pretty immediately to initiate treatment. It's important to get a rapid reduction in those light chains as soon as possible. Ideally, we're aiming for less than 50 milligrams per deciliter by the end of cycle 1, which is usually a 4-week period, but we want at least 50 to 60% reduction in those light chains. The faster it's reduced, the better the chances of renal recovery. So in order to do this, we use our plasma cell directed therapy, but this only really prevents the further production of free light chains. And so there is some controversial question of whether plasmapheresis or Plex can be used to take out the light chains that are already there. The studies and evidence is pretty poor, and it's very mixed in terms of efficacy. But what I would say is that it is also a very low risk procedure. So because it's a low risk procedure, even if there's unclear benefit, maybe it can be used very institution by institution based. And this is another time that we consult you guys. And then moving on to the last referral, which is the case that Dr. Malik had talked about to begin with, when we have someone that already has a diagnosis of MGRS. So this person had PGN-MID. Notably, the SPEP was negative, and although the kappa was mildly elevated with a mildly abnormal ratio, this is not actually abnormal if we think about the renal reference range. Again, the free light chains get cleared by the kidneys, and kidney impairment affects kappa more than lambda, so this ratio is actually considered normal in that setting. And so when we have a diagnosis of MGRS, whatever that diagnosis or whatever that subtype might be, they will often come to us just for treatment consideration. And unfortunately, as Dr. Malik has said, only 20 to 30% of cases with PGN-MID actually have a circulating monoclonal protein, which is really the exception for most of our MGRS cases. Again, here we see that. If there's no monoclonal protein, or even if there is, we still have to complete the evaluation here with a bone marrow biopsy, because both a plasma cell and a B cell can, in theory, create these monoclonal processes. So unfortunately for this case too, as Dr. Malik has said, there was no clone identified. The other thing that we often do, whether or with or without a clone identified in the bone marrow usually is a whole body scan. The reason here is that if there's a lymphoma that's underlying this, hopefully we'll see lymphadenopathy and be able to biopsy that. Plasmacytoma is the same thing with multiple myeloma. Perhaps that could give us a clone as well. So if we have the diagnosis of MGRS, really treatment depends on one, the underlying clone, whether it's B cell or plasma cell. And then as Dr. Malik has already touched upon a bit, not always do we actually need to treat if it's renal limited, whereas if it's systemic, we should be treating this. If it's renal limited and the kidneys probably can't recover, then maybe we'll be doing more harm than good by treating. So salvageability of renal function is important to consider, as is whether or not this person will be going to transplant. If someone gets transplanted kidney, then we probably want to treat to prevent the recurrence of it. So in terms of our plasma cell directed therapies, we have a lot of different types that we can use. As Dr. Malik has said, one of the best things that has changed within the past decade or so is really the introduction of anti-CD38 monoclonal antibodies like daratumumab, cetuximab. They're really well tolerated and really effective in targeting those plasma cells directly. So that is one of our strongest drugs that we use to target plasma cells. Other things that we see: immunomodulatory drugs, proteasome inhibitors, alkylating agents, steroids, immunotherapy. Immunotherapy is something that has come out within the past couple of years. What we're talking about here is really bispecific antibodies and CAR T. This is kind of like science fiction, where basically we use our own immune system. We direct our T cells to recognize different surface markers on myeloma like BCMA, GPCR5D, and enact the same kind of immune response as it would normally to viruses and such. There's different ways of giving it. Currently, it's only FDA approved for multiple myeloma in the relapse and refractory setting. So not really applicable to MGRS in and of itself. So depending on how high tumor burden it is, depending on the actual underlying disorder, there will be different combinations of these in order to effectively treat. So in newly diagnosed myeloma, we use a quad, including IMiDs. AL amyloidosis, we use Dara-Cyber-D, also a quad. But then for small clone diseases, like many cases of MGRS or other types of monoclonal gammopathies of clinical significance, oftentimes we could just use Dara monotherapy so that it's effective, but also it's a small clone. We probably don't need to use so much more. And this is really what we're looking at when we think about MGRS. One note is that if someone has a solid organ transplant, there is a theoretical concern that immunomodulatory drugs might cause rejection, but it's kind of theoretical because this idea is based a lot on case series and case reports. But because we have so many other drugs in our arsenal, like we could use so many other things, so it might as well just not go that route. If the clone is B cell, then we typically use rituximab or send them to lymphoma to treat the underlying disorder. And then, as Dr. Malik has shown you before, what if there's no underlying clone, which is the vast majority of cases with PGN and MID? And there really is not a standard of care. In my world, if I'm seeing this person, I would probably start with daratumumab because this is what we would typically have at our disposal. And daratumumab is so easily tolerated and has shown promising efficacy. That said, this is only 10 people in this study. So take that with a grain of salt, but again, very well tolerated. And so to summarize, at minimum, diagnosis is really just labs. And all the additional diagnoses are really dependent on suspicion, depending on what we're looking for: bone marrow biopsies, whole body imaging, and looking for other organ involvement. Treatment consideration depends on the type of clone that we're treating, whether it's renal limited versus systemic, salvageability of renal function, and consideration of transplant. And that's everything. Thank you guys so much. I'm happy to take a couple questions now if there are any, and then we can, yeah, sure.
We'll do 1 minute.
Okay.
For our last speaker, and we'll hopefully have a few minutes for some questions. Thank you.
one situation that we're faced with is someone has not nephrotic range, but proteinuria greater than 500 milligrams per gram a day, and we get a workup including 3 light chains, and then we see an elevated capital lambda, which we can attribute to decreased renal function when it's mildly elevated. But I've asked this question to another hematologist, oncologist, at what elevation of kappa lambda or depression in kappa lambda should we automatically send them to hematology oncology?
That's a great question. So I actually initially had more slides here to answer that specifically, but it would be way too long. So there has been such a huge attempt to kind of quantify the renal reference range in the setting of different renal impairment. In 2008, the renal reference range got moved up to like 0.3 to 3.1, pretty wide. That would be considered normal with any kind of renal impairment. I still think that that's like a good rule of thumb, but it's pretty wide. The ISTOP group, the same kind of Icelandic study that's using this giant population base in Iceland, has, as of like last year, they kind of revised the definition of light chain MGUS and when it's actually considered to be abnormal in the setting of the degree of renal insufficiency, as well as age and the level of light chains. And so there's actually a nice algorithm that I think does a good job for increasing sensitivity and specificity of whether or not we actually think that the light chains are due to renal disease or if they're due to just a monoclonal protein. The other thing, if we want to do more than just the algorithm, this is sometimes when I will get a 24-hour urine, because what the light chains really are showing is the clearance of those monoclonal proteins that is within the urine. So you could get a 24-hour urine to look for immunofixation there. And then the last thing that we have at our disposal is something called MALDI-TOF, which is basically mass spectrometry that we could use within the serum. And it has higher sensitivity than traditional immunofixation and such to detect a monoclonal protein. So typically, if you send them our way, and it's probably not a light chain monoclonal protein, sometimes what I'll get is a MALDI-TOF and 24-hour urine. And if that's negative, then I'll say probably unlikely.
Protocol to define it, or there's no certain number.
So I would say that it's very variable because of degree of renal insufficiency and because of age and such. So you Googled ISTOP and revised definition of light chains, there's literally an algorithm, and it's easy to follow. It's great. I think there's actually a calculator that's also. Otherwise, general rule of thumb 3.1. Thanks. Good. Thank you guys.